I'd like to speak to this case study where we were working with the breast care team at the hospital in Cardiff, and Helen is here, the lead breast care nurse or breast care specialist nurse at this team. I'll be drawing on Helen's inside experience and expertise here as I do this. I'd like also to mention that we here, when we drew that line at the bottom of that diagram, senior executive support, we have Mike Spencer here, who is the Associate Director for Patient Experience, and Maureen Fallon, who leads the Quality Improvement Office at the Health Board, where this work is located. So I think you can begin to see that it's a big step for senior management to come over to Dartmouth to be at a course like this. It's no mean feat for the organisation to be prepared to send them here. And Annette is here also from one of the teams, from ENT and so on. So it kind of just begins to show you the commitment of the organisation at that senior nursing and management level. This is a diagram I use, Richard and myself have been developing this to just kind of in a nutshell show to teams what shared decision making is in a nutshell. I don't want to labour this at all, but we try and say that you open up the space here for there are reasonable options here, and it's important that you understand that they're there. As soon as you do that, as soon as the patient understands there are reasonable options, then you need to talk about, so what do these consist of? What are they? And how do they compare? And actually, I don't think you can do this by talking at people. There's only so much information which is comparable between A and B, pros and cons. Immediately you've got 4 cells in your brain. There's only so much you can listen and take in. You need some tools that simplify that. You also need some tools that you take that option set away to discuss with your family and friends and other people. So as soon as you enter a difficult choice, a house, a school, a treatment decision, you need time and you need cognitive space. So you need some tools. And we think that you need brief tools as well as extensive tools. Brief tools gets the conversation going, extensive tools gets your head around it when you go home. And then when you come back, and here's where shared decision making is a bit of a problem for things that happen in one-stop consultations, when you come back to decision talk. And hopefully you're at a place where you're now informed and you can engage in that conversation. I think this is pretty simple myself, right? Really quite simple. We do it for every other aspect of our lives. Why don't we do it in healthcare? So that's a diagram, we would call it deliberation is the big space, and that's what we were trying to do in the breast care team. When we did this, the first reaction was suspicion and resistance. I'm not going to labour this, and you can see the points on here. Helen had already been involved in developing a web-based tool, BreastX. And when we first developed that, there was a bit of suspicion, you're taking away our job. And that was the suspicion among some nurses, especially when we were developing this tool and as we did it nationally. You're trying to take away our job from us. This tool is going to do what we do. It wasn't the case, of course, but that was the threat and the suspicion. They also, this team, when we engaged them, were moving to a new centre about 3 miles up the road. It wasn't the best timing for engaging this team. They had other priorities, like where's the cupboard going to be, and where are we going to have, so on. Also, some of the team felt SDM was just too fluffy. Right? What's this about? Communicating, we do that already, and actually, you can't be serious that you're investing time and resources in teaching us about this, or telling us about this. Also, it was regarded as the nurse's little project by some of the team. So there's disparaging comments like this. And also, there was very poor attendance at the introductory workshop. All the nurses came, but only one of the medical staff, the surgeons, came. However, we have here a clinical leader, Helen McGarrigle, and I celebrate the fact that we had the good fortune to engage with this team and Helen's leadership, because she's the willing skeptic, if you like. She's Scottish, but she's a willing skeptic. But she had sufficient status to bring the other, even more skeptical nurses on board. And that, I think, is critically important. And I think the microsystems work speaks to this, of having 3 people involved in the leadership. What's called the clinical lead, and that's Helen, a system lead, which kind of looks after the management level, and I think we had that in the hospital. I'll tell you about that in a second. And also a technical lead who knows some things about shared decision making. And although she's not here, we had a technical lead called Amy Lloyd, who's the facilitator, who kind of helped the team get to understand what shared decision making is and help them along the journey. I'll tell you a bit more about that. But there was the view that Helen told me this herself, that it was regarded as Helen's little project for a long time, for many months, and I think you resisted that a bit. You kind of resented that a bit. However, one of the interventions was that the hospital leadership decided to pay a visit at our request. And I think it was the medical director and the nurse director who said, we're going to come and look and see what you're doing. Actually, that generated a lot of interest amongst the whole team. The organization was taking this seriously and paying a visit to the breast care team, saying, oh, we hear you're doing shared decision making. Tell us more about it. And that very just single visit, an hour's visit by the medical director and the nurse director, perked things up dramatically. And the project takes on a new stature. Okay, so what happened then is that we had a bit of permission going on. Permission for this team to use two tools which I think have been very important. A short decision tool, which we call an option grid, and also a measurement. Tell you more about this measurement. It's based on a decision quality instrument that Karen Sepulka has been instrumental in developing and proposing, but we had to adapt it for local use. I'll tell you a bit more about that. It's fair to say, and Helen can contradict me if I'm wrong, that the nurses did not want to measure the patient's knowledge, which this tool requires, at the diagnosis of breast cancer. They say, you can't ask people questions when they've just been given a diagnosis of breast cancer. It's not the right time. Is this true?
Initially, yes. And the surgeons.
And the surgeons too, yeah. So they really didn't think this was a good idea. However, I think you're instrumental here in saying, well, let's just give it a go once. Just once, let's just give it a go, a couple of patients, see what happens. And I think that overcame the resistance, and I'll try and tell the story of what happened. The decision quality measure is now proposed to visit after the diagnosis and then after the home visit, which the nurses do a few days later, after they've explained the diagnosis and given people information. So there's a consultation process, at least 2 consultation processes in the pathway. And these are the 2 points which the decision measure is used. This is the option grid, which is used. It's a summary of a lot of information, and as you know, the kind of columns include the options, and then the frequently asked questions which are relevant to patients and ranked by relevance. Survival first, how often does cancer recur in the breast second, different rates and so on are there. So this helps, if you like, orientate that and catalyze the first level conversation about what's the options here. These are the knowledge questions. I'm not going to read them out, but they're quite hard actually. Try and answer these yourselves. Try and see how much you get right of those questions. I'm not going to go through that. But patients don't get these all right at the first visit. There's also preference questions. How important are things for you? For example, how important is it for you to avoid further surgery to your breast? Minimal surgery in lumpectomy and radiotherapy, more extensive surgery in mastectomy. So here are some preference questions. We also put in a deliberate measure, which is how ready are you to decide? And the only reason I mention this is we'll show you some data on this. Now, decision quality I'm just going to skim this slide at the moment, but high decision quality is where you have high knowledge and your preference, when you're informed, your preference is aligned to your intention. And sometimes you can have intentions that are not aligned to your knowledge base. Deciding if you like to have mastectomy when you wanted to avoid when you want minimal surgery. So you haven't got that right? So actually, there's no alignment between your knowledge, your preference, and your intention. So where you get good alignment is high decision quality. And this is the beginning, if you like, of trying to get a handle on what is the key performance index, the KPI, which the MBAs would say, about shared decision making. Okay, and here's McGarricle's tactic, if you like, was to argue to her colleagues that decision quality data pre and post would support their role. Now here just a bit of a backstory is that the nurses are under a bit of a threat because it's seen as a bit of a luxury service to provide counselling to patients at home. So there's always a question mark about whether the management would support so many nurses being employed. So the nurses felt, well actually if we had this data, we could show to the management that we're adding value to the service. That was the line of argument. Okay, but so essentially the story goes that they tried it out, and during the 4 months of data collection, only 2 of the 29 eligible patients were too upset to complete it. And I just wanted you to comment here, Helen, was that a bit of a surprise that you didn't meet more resistance in the patients?
Very much. I mean, I thought it would be much harder. I thought, we'll give it a go. And I think, as you say, once we'd got the nurses on board by thinking it's going to enhance their role, but give value to what's seen as their role. Once the nurses were on board, that was a big swing, and so it's how they then put it to the patients, and the patients dealt with it quite well. The couple that couldn't fill in, we didn't ask them to. That was a clinical judgment. We didn't ask them to do it, but everyone else, you say, and again, it was depending how we put that to them. We didn't say, will you fill in a questionnaire? We said, would you mind answering these few questions to help us when we come, to guide us in what we discuss with you when we come to see you next?
Sure. Now, remember those words, to help us help you. Yeah? That's a critical distinction. This data is not used in the aggregate at some kind of research way. This data is live to help the nurse help you, because they can spot, actually this patient hasn't understood this issue, I need to pay more attention to this. And that's a kind of use of a measure for clinical diagnostic performance. It's a diagnosis tool. And that, I think, is a critical difference to the kind of way that we've been thinking about measurement in this area before. Now, there was a lot of adaptation we had to do to the original Boston tool, because the nurses wanted to change many of the items, particularly the knowledge items, because they didn't quite fit with the way things were doing or the way they wanted to represent things. So there was buy-in by the virtue of the fact that we had many backwards and forwards things. So we don't like that, change it, and so on. So there was a kind of building up a real, this is our tool now, right? So that was an important facet. And I've already mentioned this, the fact that there's tailoring now of the information given, particularly at the second visit, to the score from the first DQM measure. Here's a bit of the data, and you can see here that the knowledge level is at this kind of 50% mark, but you can see the knowledge level here after the home visit. This is the second decision quality measure at the individual level, right? And this is kind of, aggregated now. But you can see that the nurses would make use of this and concentrate here. And what's been interesting, I think, Helen, is that you've noticed that the patients didn't understand radiotherapy so well. So you want to tell about that?
Yeah, we picked up things that we felt we'd done very well up until then. And then you look at this and you think, actually, we're not covering radiotherapy properly, and when I think about it, no we don't, or we didn't. No we do, I think. So we've learned from that, and it's been very useful for us as well. And there's been a couple of things where you think, well, actually, we need to just put a little bit more emphasis. And again, you can tailor it to each patient according to what they've said.
So this is the readiness to decide. I'm not sure if we're actually worried too much about readiness to decide anymore, but we thought we were at one point. But you can see the data here is that this is the green bar. People are much readier to decide after the second home visit than they are at the first visit. This is a nine item scale. We probably think we could get it down to 3 or 4 items actually, so we don't need 9 items. But maybe readiness to decide is an unusual feature. We're not sure about that. But what happens with the intention? Here are the intentions at DQM1. They're kind of quite a number of people here leaning one way and a number not sure. And you see by the second visit, they've gone to the sides with strong preference for lumpectomy here, strong preference for mastectomy here. So we're seeing the shift to strong intentions. And if you can marry that with high knowledge, you've got high decision quality. So we're beginning to tease out what would be a clinically useful measure. Helen, do you want to just comment on that slide a second?
Well, just we didn't want to change people's preferences. We just wanted for them to feel comfortable about it, and for us to be able to show that it is actually a good decision that the patients have made, because in breast cancer there is a lot of debate as to what's the correct level of mastectomies, and I'm not sure who's ever made that decision or where that number comes from, but you can be criticised if you do too many mastectomies, whereas I think we now have a tool that can show that whatever level we have, it's made with a quality decision.
And when we presented this data to the clinical team, one of the surgeons now said, we've got some data that protect us against the criticism of high mastectomy rates. So they're now very interested in the sustained use of this tool, is that right? Yes. So that was a real kind of motivation for a different member of the team. Helen, you haven't seen this slide before, just this issue that there are different interests in the teams about the adoption level, and I want you just to kind of mention this one. If we took away now the decision quality measure from you, how would you feel? Relieved?
No, I mean, it's something we use all the time, and we find it's valuable in 2 ways. One, in that it's actually helpful in our job, so that when we go and see the patients, we have some guidance for ourselves, but also we feel that it does give us some kind of qualitative support for our role, which I say is always at risk, because we're seen as a luxury, and so we find that that's useful, and we wouldn't like to lose it now.
Okay, I'm going to pause there.